like to say welcome to everyone to join this RS departmental seminar. My name is Marco Pang. I'm a professor of the Department of Rehabilitation Sciences at PolyU. And we're glad to have Dr. Freddy Lam to be the speaker of this lunch online seminar today. And let me take a couple of minutes to introduce Dr. Lam. And Dr. Lam is, one of our new staff who joined our department just recently. He obtained his BSc in physiotherapy as well as his PhD in Hong Kong Polytechnic University. In fact, he was my former PhD student. Before joining the Department of RS as assistant professor, he received his postdoctoral training in the Chinese University of Hong Kong, where he worked under the supervision of Professor Timothy Kwok. And this is also where he gained his experience in conducting large-scale service and research programs. Dr. Lam has published in leading journals in his research area, including the Journal of Physiotherapy, Osteoporosis International, as well as Journal of American Medical Directors Association. He received the Young Investigator Award from the International Osteoporosis Foundation in the 3rd Asia Pacific Osteoporosis Meeting. And he's currently a council member of the Hong Kong Osteoporosis Foundation and the associate editor of the Hong Kong Physiotherapy Journal. And so we're glad to have Dr. Lam to share his experience and expertise with us today. And his topic is very much related to geriatric care, because we know in Hong Kong these days, in the coming future, we'll be dealing with a rapidly aging population. So his topic today is particularly relevant. Okay, so he's going to talk about community care on geriatric syndrome. So I'll let Dr. Lam take over, and then after his presentation, we're going to have a Q&A period. Okay, so we'll have Dr. Lam take over.
Thank you very much. Thank you, Professor Pang, for the very kind introductions. So I'm Freddy. So I'm going to share with you all today about community care of geriatric syndromes. I think with all the kind introduction that Marco have already provided, so without further ado, I'll just start my presentation today. Okay, so today's presentation will last for approximately 1 hour, so that we will have some time for discussions and questions after the presentation. And the beginning of this presentation, I will talk about the aging challenge. I think a lot of you knows about the aging populations. You heard a lot about the aging populations already. But how exactly is our population is going to change, and how big of a challenge that this aging population is going to pose on our healthcare systems? I will give you some concrete figures to start. Okay, can you all hear me clearly?
Yes, very well, thank you.
That's good. Okay, and then after talking about the aging problems, then I will talk about 3 common geriatric syndromes, about frailty, sarcopenia, and falls. I'll talk about what are they, and we'll spend some time to talk about how do we identify cases in the community with these geriatric syndromes. This will be a pretty factual part of the presentations, but I think will give you a great ideas about very concrete practical ideas about case identification. And after that, I'll talk about the intervention, and particularly exercise interventions for these similar geriatric syndromes. And then I'll talk about what I have been doing in the past 3 years. That is a large-scale community project that aims at reducing falls in older people. So after all those background information that you have got, you will know about how in practice that we can do in a community in Hong Kong. And finally, we talked about my research initiatives and what are the future developments that we can do to improve care for older people. So this slide presents about the aging populations in Hong Kong and in worldwide. And the chart on the right-hand side that you can now see on the screen are the chart that's showing the percentage of people about 65 years old all over the world in the blue line. In red line is in China, and in Hong Kong is the purple line. And we're now in the year 2020. So we can see in the chart here, Hong Kong is about average in terms of having the aged populations. And we are now at about 18% of our current population in Hong Kong are over 65 years old or above. In absolute terms, it's about 1.4 million. And in this chart, you may see that we're about halfway in this aging process. And by the year 2060, the percentage of old age populations in Hong Kong will increase to over 35%, which means 2.8 million older people in Hong Kong will be classified as the old population according to current definition. So we're about halfway, and it's approximately a twofold increase that we're expecting. But I do not think that this chart provides a very good concept about the aging populations, because in this chart, we did not account for the change in young population. So in geriatric care, actually this is an official matrix from the United Nations that is called the old age dependency ratio. So the meaning of this ratio is that the populations over 65 years old, are the old populations, would be divided by the population age of the younger population that is currently working. So here I assume the 25 to 64 years old population are those that are currently working. And this represents basically say how many young populations are supporting the so-called old age dependency population. And currently in 2020, we're here at about 0.25, meaning that we have about 4 young population taking care of approximately 1 old population. But then you can see that Hong Kong will have a very sharp increase in this old age dependency ratio, probably because the working population is decreasing alongside with the increase in old age populations. Now, in the previous chart, it appears that we're about halfway through the aging challenge. In this slide, I think it's pretty obvious that we're just starting, because by the year 2060, the ratio would become 0.9, close to 1 young population has to take care of 1 old population. And this old age dependency ratio is something that we cannot change, because it's the change in our population structure. So to be exact, the current estimate in 2060 is 0.87, 1.15 young populations has to take care of the old population. But I think there is a problem with this estimate, is that we know old age is kind of associated with dependency, sort of, but at the same time, old age does not equal dependency. So while the population structure is something that we cannot change, we can try to change independent ratio. Just a very simple estimation. So imagine if we have 5% of older people is independent in our populations, then we can basically move 5% from the top part of the equations to the lower part of the equation. And just for 5% change like that, the dependent to independent ratios will change from 0.87 to 0.67. So now we have 1.5 independent population taking care of 1 dependent population. So I think the key task to tackle the aging challenge is that we have to figure out ways to make older people independent in their daily living. And that's why geriatric syndromes is something that we would like to talk about. So I think older people is very different from young people in terms of the problem that they face. On the chart over the right-hand side, you can see that provide simulations about the difference between old people and young people. younger people often suffer from one of these diseases, and that diseases lead to different problems. So we can see diseases as independent entity. But in older people, they suffer from a lot of diseases, a lot of chronic illnesses, and all these illnesses interact and causes multiple problems that at some point, we don't know whether those impairment or disability is come from one particular disease or the interaction of those diseases. I think the terms geriatric syndromes arise to describe this complex relationships. So geriatric syndromes are those problems that arises from the interactions of illnesses in older people that often result in deprivation of independence and functional decline. There are a few common characteristics of those geriatric syndromes is that they're of gigantic number because it's not a particular disease, it's a particular syndrome there. And we have a lot of overpopulation. My apology. Okay, so I think with the aging population, the number is just going to increase. And another characteristic is it is complex because of the multiple causes in nature. So it's not easy to find a simple treatment or simple quick fix for the geriatric problem. The problems are interrelated and are often overlooked. I hope that this is the past because recently we see a lot of publications and we see a lot of media coverage on geriatric syndromes. So I hope that it's not something that we as professionals still overlook in the meantime. But when you think about, you see a frail older people on the street 2 or 3 years ago, would you think that we can do something actively to help them to improve their conditions? So geriatric syndromes is also about preventions of decline. So according to the textbook, there are a lot of common geriatric syndromes that would potentially lead to loss of independence. But today, because of a matter of time, we're going to talk about frailty, sarcopenia, and falls. These are interrelated geriatric syndromes, so we might as well talk about them in one go. So frailty is, we'll start off with frailty, and frailty is probably one of the most commonly recognized geriatric syndromes. It is claimed to be is defined as a medical syndrome with multiple causes and contributors that is characterized by diminished strength, endurance, and reduced physiological functions that would lead to an increased invulnerability for developing dependency and death. So basically, it's very similar to what we define geriatric syndromes. And some people think that frailty represents biological age. So if you have, apart from our chronological age, frailty represents a biological age of our degenerations. So the frailty concept is first proposed by Freddy and Worston back in the year 1998. And it's represented by the chart on the right-hand side. And you can see that there is no absolute starting point of this frailty cycle, but it's all interrelated and is the cycle. And the topics involved in frailty include weight loss that would cause sarcopenia that we will talk about in a minute, decrease in muscle strength and muscle mass. And because of sarcopenia, there is decrease in strength that causes imbalance and falls and immobilizations, and then it causes disability. And because of the decrease in strength, older people also suffer from a decrease in walking speed, and hence a decrease in mobility and decrease in activity level. And that decrease in total energy expenditure will causes like a loop, and again and again. And there is one exit of the frailty cycle at the bottom of the chart that is dependence. So this hypothesized frailty cycle basically encompasses what we've mentioned in the definition just now. Frailty is a pretty complex conditions that we do not have a standardized diagnosis flow for frailty assessments, but we have some commonly used phenotype-based frailty assessments. So today I'm going to introduce to you one of the assessments called the Frail Assessment. It's a 5 items questionnaire-based assessment tools. And the other one is the CHS, the Cardiovascular Health Study Criteria, which also have 5 items. But for this criteria, it involves some assessments, as you can see in the table that I'm showing you. So both assessments share some common characteristics and common construct that they need to assess. For example, fatigue, and then also muscle strength, assessed by the ability to climb stairs or grip strength, and walking functions in ambulations, assessing the ability to walk for 1 block or the walking speed. And both of them also assess weight loss. For the frail, about 5% weight loss in the past half a year. And then for frail, it also assessed the number of chronic illnesses, and for CHS, it assessed low energy expenditure, basically something that we've already seen in the previous frailty cycle slides. Come on up. Clear. Okay, one moment. I noticed that we have some marking on the slides. So, okay. Okay. So for both of these geriatric frailty assessment tools, if an elderly have 3 or above items checked, they will be classified as having a frailty syndromes. And for those who have only 1 to 2 marking, they will be classified as pre-frail. And according to a local study, the prevalence of frailty in Hong Kong is about 6 to 10%. For pre-frailty, it's about 50%. So this is a study conducted by Freddy himself in 2001. So they used the CHS criteria to classify all the people into a different category: robust, pre-frail, and frail, according to the CHS criteria just mentioned before. And they monitored the occurrence, the incidence of adverse outcomes in 3 years. So the outcome presented here is mortality, hospitalization, falls, worsening ADL disability, and worsening mobility disability. And you can see that for the robust groups, they are a lot better than the pre-frail groups, and even better than the frail groups. So the numbers there indicate the number of people have an occurrence of that particular adverse outcomes. For that, 3% of the robust older people died, but it goes up to 18% of the frail older people who died in 3 years, according to studies. So with all these adverse outcomes that we're seeing on this chart, it appears to us that frail older people are 2 to 6 times more likely to suffer from adverse outcomes. So it's legitimately something that we need to look into in views of its ability to predict adverse outcome that we very much want to avoid. So the second geriatric syndromes we're going to talk about is the Sarcopenia. So Sarcopenia is a more clearly defined geriatric syndromes that the word itself comes from sarcos, come from Greek words. Sarco means flesh and penia means property. So the 2 words joined together as Sarcopenia, which is used to describe the loss of muscle mass and function. And because of its simpler definitions and with clear guidelines on how to diagnose sarcopenia, so sarcopenia has already received the International Classification of Disease Code in 2016. So sarcopenia becomes legitimately a disease. And these sarcopenia definition was found to predict multiple adverse outcomes in a lot of studies, including falls, physical limitation, hospitalization, and mortality, etc. Sarcopenia has well definitions that I mentioned, internationally and regionally. As we're located in Hong Kong, we very much would follow the Asian consensus for the diagnosis of sarcopenia, which has recently received an update that published in March this year. So how do we identify a case with sarcopenia? According to the guideline, they recommend us to use a 5-item questionnaire called the Sawf questionnaire that assessed about muscle strength, muscle functions, and also falls. And with these simple questionnaires, the total score ranges from 0 to 10, and older people score 4 or above, as indicated to be problematic as it is predictive of sarcopenia and poor outcome. And this Sawf screening tool has been validated in Hong Kong against the Asian consensus definitions, the older definitions. I apologize because the new definition just come out like for a few months, so I guess the validation study is not yet published. So according to the old definition validations, this Sawf questionnaire has a very high specificity that goes up to 90%, but very low sensitivities. So it means that for those that have sarcopenia, it's very likely that they will fail the screening tools. But for those who also failed who have sarcopenia, this tool can only pick up 5 to 10% of them. So it means that perhaps from these findings, it suggests that Sawf might not be a very good screening tool if we would like to screen for sarcopenia, but perhaps it's the easiest tools that we can use for a quick identification of cases in a community. So I would recommend that if you really query your clients would have sarcopenia, it's much better if for them to follow a proper diagnosis flow chart that I'm showing here. So according to the consensus, older people by regional definition of 65 or 60 years or above should receive a screening for hand grip strength and physical performance assessment. So if they are fine for their grip strength and also the muscle performance assessments, they would be clear, no sarcopenia straight away. But if they either have low hand grip strength or low physical performance, they would be called to have possible sarcopenia. For those who have possible sarcopenia, they should receive muscle mass measurements. Those with low muscle mass measurements will be officially diagnosed to have sarcopenia. And if they're normal, the consensus did not mention what classification or what name we should give to that particular groups of patients. Maybe we can still call it possible sarcopenia for now. And the hand grip strength assessments is cutoff scores for the failure of the hand grip and physical performance are listed on the chart you can see now on the left-hand side. So we have separate cutoff on the hand grip strength for men and women. And for the physical performance assessments, the candidate assessments include gait speed, 5-time chair stand test, and short physical performance battery. You only need to pick one out of that 3 assessments. And then we'll follow the flow chart for the diagnosis flow. And for muscle mass, the most recognized muscle mass assessments is height adjusted a particular lean mass that is assessed by dual energy X-ray, the DEXA machine. So we also have separate cutoff for men and women for this particular outcome. And according to these latest definitions, the prevalence of sarcopenia in Hong Kong for older people is about 20% in men, perhaps because of the high cutoff in grip strength and appendicular mass, and about 10% in women. Perhaps muscle mass is a little bit difficult to be assessed. So in the guideline, they've already mentioned that lifestyle modification in diet and exercise should start in people with possible sarcopenia. So if I did not remember incorrectly, I think that means like 50% of older people or 40% of older people would need to receive lifestyle modification because they have low grip strength or low physical performance. So that's a huge number. Finally, we move on to incidence of falls in Hong Kong. So people, Chinese or Asians, and including Hong Kong, has a lower incidence of falls relative to the Western world. They have about 1 in third, about 30%, but in Hong Kong, we only have about 20% incidence of falls. I'm not sure if the word only is used appropriately here. So we can say 1 out of 5 older people falls in every year. And we can see that in the chart below, a local data that we have, women fell significantly more than men. But then men basically catch up when they reach the age 75. So what is the problems of falls? So the data suggests that about 75% of falls sustain injuries, and approximately 10 to 15% of falls lead to serious injury, of which 5 to 10% of falls result in fracture. So if we think about it in this way, it appears that fall is not really a great problem in older people because only 20%, or say only 10% out of 20% would have serious injury suffering after falls. It means about only 2% of our population. And for the fracture, we have wrist fractures, spine fracture, and hip fractures being the most common fractures in older people. But why do we care so much about falls? I think even for 2% of serious injury, it already lead to a very heavy public health service burden in Hong Kong already. So the latest update we have is back in 2002, like 20 years from now already. But back in that day, the annual fall-related excess public health service cost in Hong Kong was already 552 million, not accounting the indirect costs. So just the direct cost is 552 million. And we're now 20 years down the road, and just for the inflation and for the increase in older populations, this number pretty much over $1 billion already at present. And it's going to double again by the year 2060. And the increase in cost, I think, probably due to its association with hip fractures. So near 95% of hip fractures in the elderly were caused by falls, of which 25 to 75%, according to research, do not recover pre-injury functional status. And they have 200 times of nursing home placement risk 3 months per fractures, and that nursing home placement risk remained double at 5 years. So fall prevention becomes an important part for reducing the chance of hip fractures and its associated disability. So we come back to case identification. So what are the current guidelines on fall risk screenings? So I think the most recognized guideline we have in hand would be the American Geriatric Society and British Geriatric Society guidelines. And I've taken a brief search on the local guidelines, and they're based from the Department of Health, and they basically follow this guideline pretty much like totally. So in this guideline, there are 3 important screening questions that we need to ask older people. So the first question is whether they have equal or more than 2 falls in the previous 12 months. The second question is whether they have been presented to emergency department after an acute fall, and so injurious falls per se. And the third question is whether they subjectively feel any difficulty with walking or balance. So if the older people say yes for 1 out of these 3 questions, they would be called positive in the flow chart that I'm going to show you. So with these 3 questions screened, if the older people say yes for 1 of the 3 questions, they would follow the path on the top. So according to guideline, they have to receive a comprehensive fall risk assessment. And for the remaining older people, we still need to ask whether they have a single fall history in the previous year. If they do not have any falls in the past 12 months, they're clear in the lowest part, so that we only need to assess them periodically. But for those who have a single fall history, we need to evaluate their gait and balance. One of the most commonly recommended tests would be the time up and go test. We'll look for a cutoff time of about 12 seconds. At the same time, look for imbalance or instability during the walk. If everything is clear, they go back to the lower part of the chart. And if there is some abnormality on their test performance, they would be recommended to do a comprehensive fall risk assessment. So I think this is a very simple fall risk screening tools that we have. But it gets a little bit more complicated when we go to the comprehensive fall risk assessments, because fall is a very multifactorial problem, just like all others geriatric syndromes. So we need to screen for the history of falls. We need to assess their gait, balance, mobility, muscle strength. We need to see if they have any neurological impairments. We need to check their feet and footwear. And we also need to be aware whether postural hypotensions would be a cause for their falls. And other risk factors include visual acuity and environmental hazard. We need to look into their medication, particularly psychoactive medications. But to be honest, it's very hard for us to do medication modification nowadays in Hong Kong, because doctors, every discipline prescribe their medications individually. So it's very difficult even for geriatricians to withdraw a medication prescribed by specialists. And we also have to check their heart rate and rhythms. So, but I think from this chart, we see a lot of things that therapists as PT and OT can do to help in this comprehensive fall risk assessment. And our role is especially important when we look at this results from the systematic reviews that muscle weaknesses, history of falls, gait deficits, and balance deficits are the most important risk factors for falls. So these are something that we can do as therapists. So I think I've finished about the geriatrics problems, the introduction to these geriatric problems. And this slide summarizes the problem faced by all these geriatric syndromes. And I think by now, you would be able to spot a lot of common characteristics among these geriatrics problems. For example, decrease in strength, slow walking or walking problem, balance problems, and decrease in muscle mass. And it appears to me that these problems can be mitigated by different types of exercise that we can offer to older people. So with all the background in mind, we can look at what interventions are currently recommended for different geriatrics problems. So for frailty, so because of the multifactorial nature, the candidate interventions include nutritional interventions, educations on their condition, encourage them to move more, arrange home visits to see their home environments, and with individualized geriatric care models. And according to the stage of frailty conditions, we start off with some support and goal setting that we hope that they can do it by themselves. And then we move on to have some preventive exercise interventions. And at the end, we provide hospice cares and comfort cares for those that are at the end stage frailty conditions. But I think one of the very clear and important intervention here, you can see that exercise is the longest lasting intervention that you see now in the development of frailty conditions. So the recommended exercise include flexibility, balance, resistance, and also endurance training. And before we move on, I would like to introduce you to this very well conducted systematic reviews published last year about interventions for combating frailty. So in this study, they summarized a 46 study that investigate the effects of different interventions on frailty. And they did a very good summary on the right-hand side. So on this chart, they put in all those studies that study different interventions and its effectiveness on frailty conditions. And they arrange it in a way that on the x-axis, the more over the right-hand side means that the intervention is the easiest to implement. And on the y-axis, the higher up on the chart means that the effectiveness is better. So it's more effective interventions will be on the top part of the chart. So the best interventions would be on the top right-hand corner that I've pointed out over here. So these are the interventions that are most effective while being the easiest to implement. And you can see that all of them include exercise interventions, and particularly strengthening exercise. And in this chart, the authors try to summarize the results by putting circles for each individual's intervention protocols. And we can see that strengthening exercise and nutritional supplements is on the top right-hand corners, followed by mixed exercise over the circles over here. And then other interventions are obviously less effective that include health educations, home visits, counselings, and hormonal supplements. So I guess this gives you an idea that doing simply educations is not enough. And we need to give them proper strengthening exercise. And I think this systematic review also gives a very good idea to us that frailty is something that we can reverse. So it's something that with interventions, older people can improve. It's not degenerations that is not reversible. It's something that is reversible because 70% of the study report significant improvements on frailty status and also on the single frailty indicators. So for the treatment on sarcopenia, which is a relatively straightforward disease, the AWGS guideline recommend that they should be encouraged to do physical activities, including aerobic endurance and resistance trainings, and they should also take adequate protein and energy intake. And we have a local study published last year trying to evaluate the effectiveness of exercise interventions and nutrition supplements on muscle strength, function, and mass in sarcopenic older people. So the intervention protocols last for 12 weeks with 1 hour per section, 3 sections per week, consists of mainly resistance training. So we can see that in a table there, we presented the change over 12 weeks before and after the interventions. And we have the control group on top. The red text means a significant change over time. For some reasons, all of them have an improvement in gait speed over time. And then for the highlighted cell, it indicates that the improvement is significantly better than a control. So from this table, what we can see is that exercise with or without nutritional supplements significantly improved their leg extension strength. And it also improves group strength indeed, but the effect size perhaps is smaller, so there's no between group difference. So with or without supplementation, exercise itself is already be able to improve strength. With nutritional supplements, there is not much different in the strength improvements. But for muscle mass, we see that muscle mass is only going to improve with nutritional supplements before and after the intervention. But then the same study follow up the older people after 24 weeks, so 12 months after interventions, to see whether the effects of interventions last for 3 more months. And what we can see here is that the improvement in strength stays for both exercise interventions and exercise intervention with nutrition supplements. And the difference is like they basically have the same amount of improvement in strength. But unfortunately, without continuously providing nutrition supplements, the muscle mass actually regressed so that there is no longer any improvements on muscle function. So I think here we point to a problem is whether the results of intervention sticks. If nutritional supplement has to be taken all the time, is it still something meaningful that we need to give our patients? But obviously exercise is important. And I'll give you some more ideas like in afterwards when it talks about my researches. And for fall reduction program, I think this is the most well-studied area, that most of the intervention consists of exercise. It doesn't matter if you do it in groups, in your centers or in hospitals, or whether you do it at home, you give them home exercise, or you do home visits and prescribe them with exercise at home. On average, it's going to reduce fall rate by approximately 30%. If you do the exercise intervention well, it can reduce falls up to 40-something%. And another very important part of the fall reduction program is home safety assessment and modifications. About half of all the people fall at their homes. So home hazard is something that we need to monitor as well. So I think this summarizes all the literature reviews on the importance of geriatric syndromes and exercise intervention. I think in the first few slides, you very much can feel and very concretely know that aging population is going to pose a huge challenge to a healthcare system in the coming decades. And it would be very important for us to come up with strategies to help older people to maintain and regain independence in daily living. And frailty, sarcopenia, and falls are common geriatric syndromes. We reported a prevalence and case identification strategies that they could lead to adverse outcomes and loss of independence. And exercise is one of the most important part of the interventions that we need to do to combat these geriatric syndromes. And we know that these problems can be reversed, or frailty, sarcopenia can be reversed, and falls can be prevented with appropriately designed exercise intervention. So with all these backgrounds, we need to put these theories into practice. So I would like to introduce to you what I have been doing in the past 3 years to put these theories into practice. So I think this is a very simple chart. We first need to separate all the people into robust or with some kind of geriatric problems. And for robust people, we need to promote healthy lifestyles. And for those who have some kind of problem, we need to assess them further, like the comprehensive fall risk assessments, and then we provide specific training accordingly. So with this in mind, what I've been doing in the Chinese University of Hong Kong during my postdoctoral fellowships, I spent most of the times on runnings and designings with the support of the team there, a Jockey Club program for falls and fracture prevention for the elderly, which we targeted 2,100 older people with a history of falls in previous years. I think by this slide, you know that the screening tools we've adopted is history of falls. So here, for this part of the chart, we use history of falls as a simple screening tools to separate people into different categories. And in order to reach this amount of older people, we've contacted all the elderly centers all over Hong Kong and delivered over 70 health fall prevention talks. And in these talks, over 7,000 older people has participated. So it's a lot of work that well, we have been doing with the team in the Chinese University of Hong Kong. And in the past 3 years, we successfully recruited 2,100 older people with a history of falls. And what we do to them is we do multidimensional fall risk assessments that we assess their fall history, muscle strength, balance, visions, everything, like most of the things that is I've presented a comprehensive fall risk assessment recommended by the guideline. We also added on top cognitive function and depressions, which are known risk factors for falls from other reviews. And we also assess their bone density using DEXA because we want to know whether they have osteoporosis, so that they are particularly high-risk individuals that we need to offer them with intervention. And after conducting these multidimensional fall risk assessments, we have a nurse there to provide individualized fall risk fall prevention advice according to the assessment results that we have. And we also have a doctor in the center, so that if people were diagnosed to have osteoporosis or any other medical issues, then we can refer to the doctor for further investigation. And then, according to the assessment results and the nurse advice, participants with increased risk of falls would be able to participate in live programs, which I'm going to introduce in a bit, and it's balance exercise that incorporated in daily activity, handled by our occupational therapist colleagues, and a fall prevention exercise class that is designed and run mostly by myself. So from this program, you've already seen that there is a multidisciplinary approach. We have nurses, we have OT, we have PTs, and we have doctors all in this flow. So I do not have time to go through all the details of the assessment tools that we've used. So I just highlighted a few key components that I think would be important. So one of them is a detailed record of fall characteristics. It's not just about whether they have fallen or they have not fallen, how they falls, what time they falls, and what causes the falls. You can get a lot of information if you have a detailed record of their falls conditions. So in this falls questionnaires, we ask them about what time do they falls, whether their light condition is good when they falls, the floor conditions, the location of their falls, what they were doing while they falls, the mechanism of falls, like how they falls and to which direction they falls, whether they sustain any injuries and which need medical attention. We've got all the details of fall characteristics, which will be useful. Talks about that in a minute. And then one of the key assessment that we have adopted is the physiological profile assessment that developed in Australia that was shown to predict falls in the Western populations. We picked this assessment because it provides a clear delineations of what the potential problems is on the older people themselves. And it provides very clear assessment tools and outcomes that we can use to categorize older people. So this assessment consists of 5 key components. So the first one is vision. There's a little special things about the vision that we're assessing. We're not assessing visual acuity that you probably have gone through if you have done glasses prescriptions. Rather than that, we're assessing edge contrast sensitivity. So in the chart you see here, the older people are presented with circles that have one side that is darker and another side that is lighter. And they need to point out the exact orientation of that line that's separating the darker and lighter side. And the contrast of the dark and light side decreases as the challenging level of the test increases. And we would like to see whether the edge contrast sensitivity of the older people, this perhaps is important, particularly when older people often say that it's difficult for them to walk on stairs. And other assessment tools include assessing their lower limb proprioceptions, their knee extension strengths, the reaction times, and their balance ability while they're standing on their phone. And with this assessment, we have a fall risk level that can be generated from this set of assessments. So according to the normal data in Australia that provided by the assessment tools, we could classify older people into different category of fall risk range from very marked to very low. And there is a light band over here. This curved band indicates the normal range of that particularly age range. So young people mostly are low or very low risk, and as they grow older, their fall risk, the normal fall risk goes up. But nevertheless, it gives you an absolute values whether they're at mild, moderate, or mild fall risk. And what it also gives us is individualized score for individual items. So we know which items is the worst in the older people's fall risk category and different fall risk categories. And then it comes to decisions that we have to make is how we're going to allocate older people into different types of intervention, the live intervention and a fall prevention exercise class. So a few things that we need to consider there is we consider their fall risk levels. So moderate risk or above, because we have about 30% of our clients can have exercise class. So the cutoff at moderate risk approximately cut out 30-something% of older people. But we'll also consider whether they have history of multiple falls. If they fall very often, then it might be it is indicated. And we consider the osteoporosis status. If there's osteoporosis, it's much more likely they suffer from an injurious falls. And of course, because our interventions are largely based on exercise, so performance on physical tests is another consideration factors that we have weighted in. So how we are going to design and run a fall prevention exercise class. So first we look at the guidelines. So the guidelines tells us to include several components, resistant training, particularly for the lower extremities. And we need to provide high challenging balance exercise. So it remains pretty uncertain about what defines high challenge balance exercise. But then we also need to give them gait and coordination trainings. The training has to last over 12 weeks, 1 to 3 times per week, or 3+ hours per week. This is the recommendations provided by the guideline that I've mentioned before. But then when I was running the programs and designing the exercise interventions, unfortunately, we have some practical considerations. I think we have a lot of practicing PT and OTs attending the seminar here. So I'm not sure if you can share the similar feeling to me, that I think it was pretty difficult for older people to come to our center for 3 times a week. That the older people tends to be quite busy these days. They have a lot of activities to do. And a very realistic consideration is we have limited resources, so that we can not actually afford a 12-week programs that last for 3 times per week. It's just not going to work for us because of the resources limitation. So this is the end, or this is the outcome after my careful considerations of how I have to design the exercise components. So we need to have all those essential components ready, the strength, balance, and gait assessment trainings. And what we resorted to do is we only asked the older people to come for 1 session per week, but then we extended the exercise training section to 2 hours. And then we give them 8 weeks of training. And to make up with the missing dose, we try to prescribe home exercise. And at the same time, the exercise is designed to require only minimal amount of equipment. And then during that 2-hour session, we spend some time to talk about fall risk and to scare them a bit about how important it is to do fall preventions. And we also do some counselings, and I ask them to take pictures of their exercise venues so that I can sort of know whether they have exercised or not, and give recommendations to them on a point how they can do exercise safely at home. So we do some counseling session, hopefully to facilitate the compliance to home exercise. And for the lifestyle integrated functional exercise programs, we provide 6 home visits to the older people. So those participants for these live programs are often those weaker participants that they're not willing to come to our center for exercise interventions. So during the home exercise, home visits by occupational therapists, we'll first try to know about their daily routine, what they do throughout the day from Monday to Sundays. And then after we know about their daily routine, we try to assess their balance function at homes, and then embed appropriate balance and strength exercise in their daily routine. So for example, on the diagrams on the right-hand side, we would ask the older people to stand on one leg while waiting for the kettle to boil. So hopefully by this integration, we can facilitate habitual exercise for long-term compliance. And this is a huge challenge that I will also talk about at the end of the presentations. And by knowing their routine and integrating that in their daily life, hopefully, taking this example to be specific, every time when the older people boil water, they would remember to do the exercise. And sometimes I know that our occupational therapist colleagues also put signs on the kettle so that to remind them further. And I think we have, and further than the lifestyle function exercise program, we also saw that we have home visits anyway. By registered occupational therapists. So we might as well also handle the home safety components so that our occupational therapists can give recommendation on modifying their home condition and give advice on home safety. So I think let's give pretty much overviews about what we have been doing in the past, and which appears to be like pretty well conducted, but there are still, hopefully you would agree with me that it's pretty well conducted, but at the same time, there's a lot of things that we need to improve in geriatric care, which I'm going to talk about in a minute. So the first thing is about screening. So we talked about that in right at the beginning of the presentation, that one of the characteristics of geriatric syndromes is gigantic numbers. So there is a large number of people to screen. So for Frail, we have simple questionnaires, so it's all right. But for Sarcopenia, Sawf is not a very good screening tool, as I've mentioned. So are we going to assess grip strength and physical function for all older people? And also taking the fall as examples, as I've listed in the slides here, about 20 older people fall here in Hong Kong. And according to the definitions that we have, according to the guideline, all of them would have to be assessed on their gait performance so that we can further divert them to whether they're going to be all right or they have to receive comprehensive fall risk assessments. So just for an approximate estimates that, according to research we have in hand, 20% of older people falls, and the number of older people we have now in Hong Kong, it means that over 280,000 older people fall each year currently in Hong Kong. So are we going to assess all of them? And this number is going to double by the year 2050 to 560,000 people. So I think we have done a pretty great job already in completing fall risk assessment in 2,100 older persons in the past 3 years. But when you compare that 2,100 numbers to this number that I'm showing here in the slides, where it's far insufficient that what we're doing. So we need to think about how we can improve screening for older people in need of training. The easiest approach is we resort to do secondary prevention. So we had collaboration with the A&E departments so that we can screen and assess people who had an injurious falls straight from the A&E department. And we have made up collaboration with the orthopedic and traumatology departments in the PWH so that we can screen and assess older people who had previous fractures or osteoporosis, like they're in need of trainings. But it doesn't mean that we have to sacrifice primary prevention, because when we talk about geriatric problems, we actually talks about prevention issues that is a little bit different from the treatment approach. So in order to do a better primary preventions, we need very simple screening tools, and also considering the substantial overlapping or similarity across the geriatric syndromes that we talked about today, perhaps we can think about the potential integrations of one-stop assessments for multiple geriatric problems. So the first initiative that we've made is on fall characteristics that I've just talked about a while ago. So the tables here shows the data that we have collected on that 2,100 older people. So this is a preliminary results that we have. So I want you to pay particular attention to causes of falls. I think it's not surprising that older people, the causes of falls are often either trip and falls or slip and falls. Those are the most common fall causes that we have. So what I try to do is, I think if we can find out something from fall characteristics, it would be the easiest thing that we need to do, because we have to assess fall history anyway. But if we can get some extra information from that fall characteristics, it saves a lot of effort. So first, I would like to classify older fallers into those who had only experienced a slip and falls in the past years, or those who have only experienced a trip and falls in the past year. And then we compare them on their characteristics at baseline. So this is a brief table, but I would like you to focus on these two items. So what we have found is that people who only experience a slip and falls has a better knee extension strength compared with those who have a trip and falls, which is significantly different across. And they also tend to walk slightly faster, but not reaching significant levels. And for those who trip and falls, they're more likely to be recurrent fallers, but not significant as well. So it hints to us that the two types of falls are different in those people. So we do some further analysis in order to augment the difference between the slip-only and trip-only group. We separate them into recurrent fallers. So in this table, we only select those who recurrently slip and those who recurrently trip. And you can see here that the difference in knee extension strength exaggerated. And there is a close to significant difference in grip strength as well. So it appears to be that trip and falls, people who trip and falls and recurrently trip and falls have worse physical function. And it gives us an idea that elderly who trip and fell are potentially better candidates for fall prevention exercise intervention, particularly in those with recurrent trip and falls. So if people around you, your patients or your clients in your community center report recurrent trip and fall, it probably is an alarming signal that you would like to look into. And another initiative that we're thinking of doing is about simplifying the sarcopenia diagnosis flow. So I think sarcopenia is important in large because it predicts adverse outcomes. And this table shows that it actually does predict adverse outcomes in terms of physical limitation, recurrent falls, hospital stay, and mortality. But what we're trying to do here is to see whether it is actually important to do all the assessments on the recommendation line. So what we're trying to do here is we're trying to see the predictive values of the accumulative predictive values of each items. So we put in age first as a reference in these tables, and then we put in Sawf, the questionnaires that I've mentioned before, as the first steps. And we can see that the additionals of Sawf yield an area under curve, the larger the better, about 0.69 for physical limitation in men. And the darkened cells mean that there is a significant increase in area under curve, so a significant increase in predictive ability relative to the previous steps, in this sense, age alone. So Sawf significantly, including Sawf, significantly improved the prediction of physical limitation in men here. And then in the second step, adding grip strength assessments. And then the area under curve rise to 0.686. That is significant improvement because this cell is darkened. So basically, darkened cells means that, on this table, means that it adds significant value relative to the previous steps. And as you can see in this table, basically all predictive value exhausted by the steps of gait speed. So we assess Sawf, we assess grip strength and gait speed, then it's good enough. Adding in further 5-time chair stand or height adjusted appendicular knee mass is not going to improve the prediction of adverse outcome any further. You may argue that there is one point over here that is darkened as well. But then when we look into the odd ratios, surprisingly, this is 1.27. It means that a high height adjusted appendicular knee mass in this particular research is associated with an increase in chance of suffering from physical limitation. And this is not something that we want. So it appears that assessment of muscle mass might not be necessary for the prediction of adverse outcomes. So we perhaps can save quite a lot of money from doing DEXA scan on muscle mass. And I think this also has some implication as well, is on our treatment outcome. So what we are looking for. Are we looking for improvement in muscle mass or improvement in muscle strength? I guess this result perhaps gives hints that might be improvement in muscle strength and function is good enough. And we can save some effort not to aim at improving muscle mass, which is much more difficult. And the final initiative is about the one-stop assessment approach that I talked about a while ago. is considering frailty is highly associated with falls. So is it possible to use frailty screening tools for fall identification? So also using a data set that we had, we try to use a pragmatic approach in this analysis, which is published last year in JAMDA. So fall history is the first thing that we put in because I think we all know that fall history is the easiest thing to assess and that predict falls in older people. So it would be very important that anything we do on top will be independently predictive on top of fall history. So then on top of fall history, we put in the CHS criteria I mentioned a while ago, and also the frail criteria as well. So what we have found here is that only in women's, adding frail criteria appears to significantly improve, like frail is an independent predictor of falls in women's. And I'm particularly glad about this result because frail is a very simple assessment tools to do, only 5 items questionnaire-based assessment. So we go a step further and try to explore the clinical values of the frailty screening tools in identifying fallers. So we use an approach called classification and regression tree analysis, basically a decision tree diagram that I'm showing you here. So the first step is we have all women that we have in a sample, about 1,500 older women. And the outcome, the percentage there shows the percentage of that population that are recurrent fallers prospectively. So among all women, about 6.7% of them will be a recurrent fallers in the coming years. That's what this cells means. So a pragmatic approach, the first step we have is to stratify older people according to fall history. So those who had no fall history, 4.7% of being a recurrent fallers, and those who have recurrent fall history, there is a 17.6% of them would be recurrent fallers. Single fall history, 10.4% chance of them to be recurrent fallers. And then we add in the frail questionnaires and further stratify older people into different groups. And the cutoff score is determined by the analysis themselves. So for no fall history, the cutoff would be 1, and for single fall history, it would be 3, and then fall history would be 2. And this is the result that's shown from that analysis. So we think that it is quite obvious that frail questionnaire does significantly improve the case identification. Like at least for those who screen positive, they're at least double at risk relative to those screen negative on the left-hand side here, 3% to 4% to 8%, 10% to like 40% in factors. But I think that according to the guideline, again, those who have recurrent fall history, they have to be screened using comprehensive fall risk assessment anyway. So it's less important. And then for those who have a single fall history, who have no fall history, even they screen positive, they only have about 7.5% chance. That's not so high. And realistically, we need to do all assessment for like the vast majority of all the people, and that requires a lot of work, and that might not be as well that important. So the key groups would be the one in the middle that we need to do. But using a cutoff score of 3, we have only very little people that were screened positive. So what we're trying to do, so we try to do a further steps and tune down the second outcomes in second cutoff at 1. So in people with a fall history and a frail cutoff score at 1, they have a close to 15% chance of being a recurrent fallers in the coming year. And this number goes very closely to those with recurrent fall history, and substantially different from those who are screened negative. So I think that this frail questionnaire potentially useful to identify high-risk faller in older women with a single fall history, which is the most problematic groups when we think that on the original guideline, we need to do gait assessments, and perhaps with frail in women, using frail can help us to further screen out some high-risk cases that can save us some work. And I think I'm kind of running out of time, but then some further information, some brief informations on the optimal training protocol. My colleagues actually published a paper this year talking about the optimal amount of physical activity in relation to falls. So I think in most of the guidelines that we have out there, including the ACSMs and etc., recommended 150 minutes of aerobic exercise every week, and then 150 minutes of exercise every week. But then they did not set a upper limit for that exercise amount. But what we have found in this study is that we invited about 600 older people to wear an actigraph so that we know the objective data. We have objective data to know about the activity level. And then we use the same classification tree analysis to separate them into 3 different groups. And we found that the moderately active groups, like in the middle here, has the lowest incidence of falls relative to those who are inactive, as expected, but also relative to those who are highly active, even after adjusting for a lot of covariates, including wear time. So perhaps it's give us some hints that might be too much activity is not good for older people as well, in part perhaps because of the additional time being exposing to potential fall episodes. But unfortunately, with actigraph, we cannot categorize the type of activity. So I think this is something that we need to do some more research on to identify what is optimal in fall risk activity. So what about the future development of geriatric cares? And we know that we need to optimize screening protocols. We need to optimize training protocols, and we need to do better in public education. So I think it would be crucial for us to establish efficient models for promoting physical activity in older people. I do not think we have any effective promotion campaign that is going on. This is a very challenging thing to do that we need to address. And then we need to try to streamline the case identification process, especially for the screening tools for sarcopenia and fall risk. And we need to identify optimal training protocol for reversing and attenuating geriatric syndromes. We have slightly more research on falls, but for optimal exercise protocol for frailty and sarcopenia, we do not have much ideas about the optimal training protocols. And also for falls, what is the optimal level of challenge is something that we need to think about. And we need to also think about cost-effective training model because of the increasing older populations. Perhaps we need to consider a train-to-trainer approach that we try to migrate to role of therapists, to program designer, and supervisors. And then we have assistant to conduct those trainings. So it could be cheaper and more cost-effective. And key roles is we try to improve compliance to exercise programs. So those are the future directions that I've just mentioned, but I think there are a few problems and questions that I think we all do not have answers. And we need much more work. It's the pitfalls of geriatric cares in the community. The first is, most important, is sustainability. So the benefits on falls would fade when the older people stop exercising. So if they stop your classes and they don't exercise regularly at home by themselves, the benefit that you induce during the class would fade over time. And according to systematic reviews, only about 30% of older people continue to exercise after 1 year. We end the exercise classes. So this would be a huge challenge to improve compliance, as I've mentioned before. And that's why the live protocol is something that could be valuable if it improves compliance to a great extent. And because of the sustainability problems, it also gives rise to discharge problems, because what are the discharge criteria for older people with geriatric syndromes? When I was running the community projects, I think you would all agree with me, if you're working in community center, is that we do not have the resources, and it is physically impossible for us to hold everyone in the community center without the discharge mechanisms. Like after a set of exercise training, they have to go. If not, we do not have time and resources to take new cases. So what should be the discharge criteria remains something pretty uncertain. So with these sustainability considered, it would be very important for us to increase the self-advocacy of older people in leading an active lifestyle. But then it goes back to the problem that I've mentioned. We do not have a very effective promotion campaigns that we have. And finally, this is something very difficult to address, is that we are uncertain if improving frailty status and muscle strength and function could eventually changes the risk of hospitalization or mortality. Like in cohort studies, we know that frailty and sarcopenia predict hospitalization and mortality, but we kind of do not know whether we give them exercise interventions and the frailty status improve, whether that is going to change their hospitalization risk. It's something very difficult to do, and I guess we can just have faith that it's going to work, because it would require a huge randomized trials, because incidence of adverse outcomes are pretty rare, and we need to have a very large sample size. Nevertheless, I think this goes to the conclusion of today. I think I hope I've given you a brief introductions and practical ideas about the case identifications of different geriatric syndromes mentioned in the presentation today. And I hope that this presentation also helped to raise your awareness that helping older people to maintain and regain independence in daily living will be an important task in the upcoming decades because of the aging populations and the problem faced by the older populations, and that we have a lot to do to advocate a simplified flowchart that I have demonstrated in the presentation. And also, I think that with the establishments of district health center, they're trying to advocate primary preventions and primary cares for the older population. And we, PT, OT, and allied health professionals have a huge role that we can do, and it's basically our stage in preventing geriatric problems, even under the current administration. So finally, I would like to acknowledge my postdoctoral advisor, Professor Timothy Kwok, and the center that I was working for when I was postdoctoral fellowships at the Chinese University Jockey Club Center for Osteoporosis Care and Control, because most of the data that you see in the presentation here is supported by them and collected by a joint effort of the team over there. And of course, we need to thank the Hong Kong Jockey Club Charity Trust for providing funding so that we can run the community project that I presented just now. And finally, I'm new in the academic world, so I would also like to invite all of you to join me in improving cares in the older populations. So I think I'm looking for potential collaborations, or actually just ideas and feedbacks from every one of you working with older people, no matter whether you're working in elderly centers, hospital, or elderly homes, or you have a special thinking about care of older people, then you're welcome to talk to me and for feedbacks. And I think clinician feedbacks are crucially important to generate practical research and community projects. So I guess we could join hands to work for older people, and we can work together on community, on research projects, and perhaps I can give you some advice and we can have some discussions on appropriate case identification, appropriate treatment options, and even just how a case should flow in your center or in your hospitals. Especially if you have secondary prevention ideas, we can work together in improved cares of our geriatrics populations. So I think this concludes the presentation today. So I would like to recommend welcome question and discussion from the audience.
Okay, thank you very much for Dr. Lam's presentation. A lot of, different research findings and experience sharing, and I'm sure you'll have some questions for Dr. Lam. And we have roughly 10 minutes for the Q&A period, but there are a lot of participants here. So I think if you have a particular question, then please type your message using the online platform. Then so everybody could see your question, and then Dr. Lam can address your comments, okay? So for those of you who have, a burning question, can you please, type your message? there so that we could see what you would like to ask. Can you do that? Yeah, because we have about 10 minutes for the Q&A. So I'm going to give you, a couple of minutes to type your questions. Maybe I'll start first, and then the audience, you can take this time to, post your question. Freddy, I'd like to know, you at the end of your presentation, you mentioned, the district health center, and I think, one of the major mandates, I suppose, is to promote primary health. And so prevention and screening, these are very important things, right? But I just want to make a comment on that is like the operators of the DHC, they need to know how important we are, as allied health professionals. And in the area of screening for fall risk, in the area of, interventions to prevent falls or to reduce falls, as you have shown in your presentation, assessment of walking, right? Assessment of muscle strength. And in terms of exercise interventions, these are our specialty areas. And I think the operators of the DHC, the existing and the future operators, need to know this. Okay, so I think I do agree that the allied health professionals, I think particularly physiotherapists, because we are trained to do, exercise interventions, prescribe exercise, muscle strength, mobility, these are our key areas. So I think the operators need to know, okay, so that the clients would receive the best care as much as possible, right? So we want to make sure the clients are in the right hands, so to speak. Okay, so this is my comment. When I heard you raise, the issue of DHC, I want to make a very strong point here. Okay, all right. So a couple of questions. And do you think, this is the question raised by, you can read the first question here. Do you think how early should we, start working on, the prevention of the geriatric syndrome? Are we talking about in the 50s or 60s or even earlier? So what is your take on this?
I think the earlier the better, but I think we have to approach these questions in two different approaches. If you are the older people or you're working, you recommend older people around you, of course the intervention start as early as possible, because building up activity takes time. And when you're younger, like say 40 and 50, you can engage in more challenging activities. And particularly, we know that after the age of 50, muscle strength and muscle mass drops pretty dramatically. And especially the type 2, the fast-twitch fibers, which are important for prevention. So the earlier the better. But on the other hand, it's about we do interventions as the primary care provider, let's say the DHC has mentioned, as early as we can. Then we have two huge population to cater. So I guess for those centers, the optimal cutoff now might be 70 or 75 years old for older people. But then for more politically correct answers would be 65, because that's the current definition of old age, older people in Hong Kong currently.
Okay, thank you. And second, I think it is a comment raised by Anthony. Using the self-help group model with technical support from PT can solve the problem of discharge in the geriatric care. This is the Australian model, which seems to be very effective. And the active involvement of physiotherapists is important.
Yeah, I think I totally agree with this comment. So that as far as I know, but I might not be in a perfect position to talk about this now because I moved to PolyU. But at the same time, I think it might be a good chance of promotion campaign. Is because the Chinese university I've cited have a new round of prevention community project as well. And in that project, we try to mitigate with community center that we go to, as well as the elderly there to be advocates so that they can continue to lead the exercise class by themselves in a community center. And I think that idea is pretty similar to what Anthony has mentioned in the comments.
Okay, thank you. And the next question, is there any recommendation for the new community initiatives in this area for those organizations with very limited resources, but they really want to do this, but they have limited resources?
I would very happy if you come to talk to me so that we can talk about in detail what kind of resources and what kind of patient source that you have in that community center. I think a health talk is the cheapest thing that we can do. So, but at the same time, asking for resources so that perhaps PT or OT can come to do exercise demonstrations, and at the same time training up a few volunteers at the center to help lead the exercise class and provide a full advice. That would be something that requires very little resources and might be not so effective, but it's better than nothing.
Okay, so the next question, I think it's a very good question, like the COVID-19, all these different things and the development of technology. In terms of exercise training, did you use any particular devices or technologies that helped?
I'm actually planning a research studies about that, to do remote exercise training using tele technology. A brief report on what I found online is that researchers on stroke populations, neurological populations, or cardiopulmonary population use a lot of tele-rehabilitation programs. And I'm pretty certain that our colleagues working in HA use some of those technology as well. And research findings shows that it is effective. And one paper published even said that remote exercise classes is equally effective than to face-to-face classes compared in the cardiopulmonary rehabilitation. So I guess it has great potential. But there's one thing that we need to pay extra attention to is when we talked about geriatric syndromes that I've mentioned, let's say fall, we have high challenge balance exercise. This would be pretty dangerous if we do not provide sufficient supervision. So this is something that we need to pay extra attention to. And another initiative is in the Australia, there is even initiatives to do a whole, to put the whole exercise intervention online so that the elderly can do the assessment themselves and they read all those precautions that I've mentioned. I think you can take a look at the standing tall programs if you have time, and you know how they can do it using fall prevention as an ultimate protocols for tele-rehabilitation.
Okay, I guess this is the final question raised by Simon. Yes, the screening. Okay, screening needed for the general public, and is exercise good for all ages, regardless whether that particular person has a fall history or not? That's the first question. And any programs to train the helpers, like the family members or the domestic helpers, to supervise the elderly people to exercise at home, I suppose.
Okay, for the first questions, I think screening, of course, is needed in general public, and that's why community involvement is very important, and we're running community projects. But we also need to gather information from there so that we know how to optimize the screening in the future, and that is involved in research components. And for this second part, isn't continuous exercise good for all ages? Of course, yes, but so I think promotion of healthy lifestyle is very important. We need to pay extra attention for frail older people. So we need a screening, so whether they fail once, twice, or more, and they might not be that active at the end. So we need to reach out for those inactive older people, which is a difficult task, and other difficult tasks we need to do. And we need to advocate and promote exercise to them. And that's why we need to access the screening strategies, because we need to reach out to those people at the high risk for cost effectiveness. So finally, their program to train the helper. this is something that we try to do. We try to train volunteers, part of the Jockey Club program that I've mentioned before, and we'll continue to do that. But if you are particularly mentioning about living in their homes with helper, and those are the unreachables. A lot of them are the unreachables. So to me particularly, while working on community projects. So I would also welcome collaborations and assistance indeed from colleagues working in enhanced care so that we can reach out to those very weak older people that live at home and we can see what we can do for them. I know that they're particularly in need.
Yeah, I guess one final comment raised is, shall we start earlier, like the middle age, as far as prevention is concerned? So if we start screening earlier, it might be a better option.
As I've mentioned, it's again go back to the questions about the resources management. Yeah. If we start early, how much resources we can put in to actively train them. We're actually taking away the job of those private gyms if we're going earlier. So that might not be the best way that we do that. But of course, as Simon have already said, encouraging active lifestyle will be important in middle age. But if we're looking at prevention, perhaps we need to really screen for risk for better resources usage.
Right. So so my final comment is that I think you have presented very nice research findings on prevention of falls as well as screening. And I think the next step would be for you to promote your protocols. I think those are very useful. And because a lot of the research was done in the Chinese University of Hong Kong and their affiliates, right?
Yeah.
And I think we need to do a lot more promotion so that more people are aware of these different protocols, so that they could apply some of your ideas in their own settings. And I think this is something that we need to do in the near future.
That's another challenging question because it's need to negotiate with a lot of stakeholders.
Yeah, it's the the implementation and so that more people are aware of it, right? They might choose to modify the protocol or whatever, but I think what is very nice is that you have the research evidence, okay? And so the next step, it would be nice to see a wide implementation of this, screening and intervention protocols.
Yeah,
I think that would be the next step. Okay, so I guess time is up, and I thank you for all of your participation, and I hope you have learned something from this presentation, and I look forward to seeing all of you in our next departmental seminar. Okay, and yes, thank you, Dr. Lam, as well, for your presentation. Okay.
Thank you.
So thanks a lot, and stay healthy, everyone. Okay, thank you.
Goodbye.
Bye-bye.